Good evening. This is Dr. Alaswad. I'm presenting to you a case about how to deal with difficult epicardial collaterals. This patient is 72 years old with an RCA CTO, which we thought it's actually easy to tackle, and there might be antegrade channel. It was well-defined proximal cab, the occlusion less than 20 millimeter. There's a calcification and very mild bend, pretty much JCTO score 1 probably. There's no previous attempt. So we always come ready. So we put 2 guide catheters, 8 French from the groin, AL1 guide catheter in the RCA, and EBU4 in left main coronary artery. And we started with an antegrade wiring, starting with pretty much XTA wire, and you can tell we already here the wire looks in a different position than the RCA. We tried multiple attempts. We took basically another polymer jacketed wire. It went in the same place. We are looking to see if the wire even overlap with the RCA. Probably overlap in a small short segment, but then we don't know where is the wire. Is it in a small cider branch? If it's in the same, we really don't know. This is here. I tried to take an antegrade Carlino to start the dissection. So here basically you take a syringe, you attach it to the microcatheter and you inject. And if you notice here, we already started the dissection antegrade, hoping probably set up for re-entry or go retrograde. However, the distal targets are not good for re-entry with a stingray. After we injected, I used a radar wire, which is a polymer jacketed wire that actually kind of the Teleflex Pilot 200, and it went this way, and the fellow with me thought we actually went through lumen. I wasn't really sure, almost sure we are outside the lumen. So here's the confirmation. The lumen is in one side, and the wire is just overlapping with it, which is not a bad position for re-entry. However, the distal targets are poor, so I want to look and see if we have a retrograde. If you notice here, all the septals, we have 1, 2, almost 3 septals, none of them connected. We tried all 3 septals, and then we went here. If you see the microcatheter in the left circumflex, the microcatheter is there. We're going to try to see if the epicardial collaterals. This wire went into the atrial branch, so we took the atrial branch. The best view to look at the left circumflex to posterolateral branch collaterals is the aleocrani or straight crani, because that actually shows you the distal posterolateral branch, similar to looking at the bifurcation of the RCA. So if you think about it, if you're going to look at the collaterals that go into a branch, you look what the best view shows that branch, actually that will show also the collaterals. So that was not it. Then we injected selectively in this branch. I couldn't see the distal, but when you inject in this third branch, right in the middle between the first one, which is atrial branch, and the second one, which is probably posterolateral, you can actually see the RCA fillet. However, there is a trick to this. Before you take the syringe off, try to do multiple views to see if you can understand the trajectory of these collaterals. So this view here in the ariocaudal was not really any better. This view here in the aleocranial it shows it, but it's not clear, but you can tell the collaterals are actually go through the AV nodal branch. You can tell here. If you look at it very carefully, and it fills the posterolateral branch. the problem was how to get to this collaterals. So if you look here, there is basically a branch that goes down and bends up and bends again to fill this is epicardial collateral branch. And how to cross this? You use a Suho wire. It's the least traumatic is 0.3 gram tip wire, and you advance it, and that actually will get you there. Sometimes if you cannot make the bend, you take a Sheehan wire and you make a really sharp bend on the tip, and that will take you where you go. So basically, we were able finally, we struggled a little bit, but we were able finally to get the wire going down in the collaterals. And here, we did actually tip injection. I did not record it, but this is a Suho wire. We're trying to go down the AV nodal branch down to the pistolateral branch. The problem was the wire kept going into every small branch. Then when the wire buckled, I felt a release of resistance. Although it is O3 tip wire, you still can feel some resistance. And then watch here, so how the wire can go, gonna bend, we're trying to kind of bend it over, and then felt resistance and then went exactly where it was. So we advanced the microcatheter. I actually had to turn this microcatheter because I used the Corsair, the Caravel initially did not go. So basically we dilated and we stented, and this is basically stenting. Now you have to remember this was very difficult epicardial collaterals, and this is actual epicardial collateral. So basically post dilatation, I see this. This is LS2. However, the patient is very stable. The patient did suffer from a little bit of bradycardia and hypotension when we put the microcatheter through the AV nodal branch, but after we dilated and integrate, he was good. So if you look here, there was a diffuse distal disease, and I had to stent it. And now I have a collateral, epicardial collaterals that I struggle to cross, and the question is it perforated? So before you remove your gear, you take and you remove your externalized wire. So you take an antegrade microcatheter over the externalized wire, and you make the two catheter for retrograde microcatheter and antegrade microcatheter touch, and you remove the wire and you do tip injection. If you notice here, notice that there are actually some contrast that's going out here. So that tells me that epicardial collaterals is perforated. Now this is from one side, and now once you have an epicardial collateral perforated, you need to plug it from both sides. If you plug it only from one side, the other side is going to continue to fill it. So basically, if you notice here, we injected in this now from this collateral, and this, if you notice here, it's filling also the perforation. So now it's incumbent for us to plug the collateral from both ends. So what we did, this is here, we used an axiom guide catheter with a retrograde microcatheter. We put it, and we put actually, first of all, I put a coil in here, and to my chagrin, it turned out that actually the extravasation is still there. So I actually coiled a small, very small cider branch. So I went back in with the microcatheter and I coiled the branch that was bleeding, that actually the epicardial collateral